So welcome everyone. Thank you for joining us for the next session in the Canadian Breast Cancer Network series Questions and Experts, where we'll be speaking with Drug Access Navigator, Michele MacDonald. Welcome, Michele.
Thank you.
I'm Jen Gordon. I'm the Director of Operations with the Canadian Breast Cancer Network, and I'm pleased to welcome everyone who's joining us today. For those of you who may be interested in previously recorded questions and expert sessions or other webinars that CBCN has hosted over the past year or two, I will put a link up in the chat so that you're able to link to subscribe, to sign up to be notified of future sessions and also to view our previous sessions. CBCN will be holding our next Q&A session on November 10th, so mark your calendars, and we'll have medical oncologist Dr. Seskon answering your questions about triple-negative breast cancer. And again, I will put the link in the chat momentarily on how you can subscribe to our e-newsletters to be notified of that. I would like to extend our sincere gratitude and appreciation to our sponsors for today's session that are making this possible. So our gold sponsor, Beatrice, our silver sponsor, Novartis and Roche, our bronze sponsors, Ontario Trillium Foundation, AstraZeneca, Knight Therapeutics, and of course, Pfizer Oncology. We do have some questions submitted in advance, so we'll start with those, but we will be answering your questions live throughout the event. So if you have a question, there is a Q&A button that should be towards the bottom of your screen or somewhere along the side of your screen, and you can use that to type in your questions. If that for some reason isn't working, please feel free to type into the chat as well. And I would now like to welcome the host for our session, Kathy Amanda Leah, who is the chair of the board of the Canadian Breast Cancer Network and has also personally experienced a breast cancer diagnosis. So she really understands how critical it is to be able to access proper treatments and not have the financial barriers to do that. So Kathy, I'll turn it over to you.
Thank you, Jen. Hi, everyone. It's nice to be back for another session. So welcome to everyone, or if it's your first time joining, welcome. So I'm pleased to introduce our guest expert for today, Michele MacDonald. Michele is a drug access facilitator at the Juravinski Cancer Centre in Hamilton, Ontario. She is also a regulated pharmacy technician and a patient advocate. She has been working as a drug access facilitator since 2006 and was one of the founding members of Ontario Drug Access Navigators, which has served as a model for other provinces. In addition to her professional experience helping oncology patients access the drugs they need, she herself has personally experienced an early stage breast cancer diagnosis and more recently has been diagnosed with metastatic breast cancer. So she brings a perspective of both the healthcare professional and the patient. Michele, welcome, and I'm looking forward to our discussion.
Thank you very much, Kathy. I'm very happy to be here today.
Great. So let's start with our first question of the session. This is a submitted question. What is a drug access navigator or facilitator, and what role do they play as part of the healthcare team?
Okay, so a drug access facilitator also goes by other names as well. Some centers call them medication reimbursement specialists. Some call them drug access navigators, drug access reimbursement specialists. So what we do is we work with the oncologists when they want a certain drug for a patient that is not currently funded, usually by Cancer Care Ontario or provincially funded. So it's our job to work with the patient and the physician to try to get access to the medication that's required for them.
Great.
So we do actually play quite a big part these days in the oncology setting for sure.
Okay, I just want to know if you can clarify, how would a patient know that there is a drug access navigator? Do all centers have navigators? And could they still connect with someone if the cancer center does not provide one?
Yes. So it depends on the center. I think quite a few of the cancer centers do have drug access navigators. I think there's very few that don't have them. But sometimes patients get information from other patients and they will mention it to their oncologist. Another thing is, I believe we're on the Cancer Society website. somewhere in there. I tried to find it earlier this morning, but we definitely are in there. And then also you can ask your physician. And if we're available in the center, we would come down and see the patient. If it's a center that doesn't have a drug navigator, sometimes we will work with other facilities to help the patients. We do have 2 physicians that work part-time at another, it's actually a hospital, but they do have a very small oncology unit, so they don't have a navigator. So we will actually look after any patients that they need, kind of help with medications.
And so if someone comes in and is quite new to a cancer diagnosis and doesn't understand that there is such an access, who would relay that information to this patient?
Usually the physician or the nurse would let the patient know that there is somebody available to help them navigate through that process. Okay.
It's just making sure that everybody understands that there is such a tool for them.
Yeah, and that's a huge part of Ontario Drug Access Navigators of Ontario, which is ODANO. We try to keep, relative in the patient population so that they are aware that this is a very popular kind of position that most cancer centers have. So we really try to keep the education and keep our name kind of in the news, so to speak. So we're on Facebook and Twitter and LinkedIn and all of those things. So we do get questions submitted on our Facebook and our LinkedIn profile as well.
Great. Thanks. Jen, do you have any live questions that you'd like to get to?
We have a follow-up question to that, actually. So can patients self-refer? Like patients in Ontario, could they actually self-refer to a drug access navigator through the ODANO website? And what about patients who are not in Ontario? Can they also refer to the ODANO website or to a drug access navigator through that? Or how would they go about accessing someone if they haven't been connected in their cancer center?
Okay, so if it's in Ontario, they could log into ODANO has a public website for patients can log in, and there's a patient section, and they can submit a question, and one of the board members would get back to the patient within 24 hours. And we actually get quite a few self-referring patients because patients tend to talk in the waiting room and so forth, and sometimes we get people calling saying, like my brother-in-law went through cancer a year ago and somebody helped him get medication. Is there any way that I can get help as I am now a patient? So we do get quite a few of those self-referrals.
And then what about the out-of-province ones? There's a question here about whether or not this is connected to Manitoba Cancer Care. So obviously ODANO's not, but if someone was to type in and ask a question to ODANO, could they maybe be navigated to somewhere in Manitoba or their province that could help?
Absolutely. So there is actually another website that we've kind of been involved with. It's called DAC, which is Drug Access Canada. Okay. And they can log into that website and they can be redirected to whatever province that they're in.
Wonderful. I'm going to put both the ODANO and that website in the chat momentarily as well. Kathy, we'll go back to you and then take a few more questions from the audience.
Okay, so I have another question that was submitted to us. And the question is, if a treatment that my oncologist recommends isn't covered through public provincial funding, where else might I find funding for this?
So we kind of do a little checklist. We obviously start at the beginning. Is it funded by the province or Cancer Care Ontario? No. So then we ask the patient, do you have private insurance for us to look into? If the answer is yes, then we will do usually prior authorization forms to that particular, whether it be Manulife, Great West Life, Green Shield, so forth. Submit those forms to the insurer. If it comes back approved, great. If it comes back denied, we always appeal. If it comes back denied a second time, then I always ask the patient to contact their employer directly through the HR department to make an exception for them to just add that particular drug to their particular policy. And we usually ask the physician to kind of give us as much documentation as possible, and we get the patient to submit that directly to their employer. So we have had some success going that route. If the patient doesn't have insurance, then we look at, okay, are you available for Trillium, which is, Ontario drug benefit? If you're under 25 or you're over 65, is the medication covered through Ontario drug benefit? If so, then we do the appropriate paperwork. If not, then that's when we go to the patient support programs. And we usually involve the patients in any programs that are available anyways, right from the start. So then that's kind of like our chain link of kind of command that we tend to follow.
That's very good. Sounds like a lot of work and a lot of process, right?
It's a lot of paperwork and a lot of documentation and, a lot of research and that. But I would say out of 100 patients, there might be 1% that we cannot get the drug for the patient.
And would there be some compassionate care or something? Ultimately, does anybody get denied is my question, actually.
Very rarely. We usually can, however we manage, whether we're going through private insurance and appealing and, asking employer, sometimes we encourage patients to, contact your MPP's office to try to get the drug added, a little bit quicker. A lot of times patients will have GoFundMe fundraisers if it's something that's just absolutely not covered. But also the PSP programs do offer a lot of help, whether it be compassionate. Sometimes they do a financial assessment. So depending on your income, they will, pay a certain percentage and you're just required to pay the copay. Some of them just have kind of cost sharing right off the bat that they only offer 50%. So you're paying 50%. There's so many varieties of situations, but we are usually able to get the drug for the patient in the end.
Well, that's reassuring. And I hope that we'll be in a place one day that nobody has to go through the very end of the route. Thank you for answering that. I have another question. Can patients submit the forms to the various drug funding programs, or does this need to be done by a doctor or other healthcare professional?
Usually it has to be done by a healthcare professional for a few reasons. One, we usually like to make sure that the patient does meet the eligibility requirements for that program. Second, the physician usually does have to sign the enrollment form as well as the drug navigator. And most programs actually have the prescription embedded in their PSP forms, which also the physician would have to fill out. The patients do have to sign the form as well, but most programs do take verbal consent now. So
Great.
So we don't recommend patients sending it in, because usually the program will contact us and say, hey, we received this enrollment form. Are they a patient of your center? And then if so, then we end up doing the paperwork a second time. So it's easier for the patient to try to get a hold of a Drug Access Navigator to initiate the process. It just helps facilitate things a little quicker so that there's no delays to the patient getting drug.
Okay, that's.
Oh, Kathy froze for me. I think it's her that's frozen. So maybe what we'll do while we wait for Kathy's internet to kick back in is actually take a couple live questions. Oh, we have you back. Go ahead, Kathy.
No, I was just going to say that the next question, I don't want to leave out any questions that were submitted, is around the appeals process. If you have anything else additional to say around that, that would be my next question that was submitted. If funding has been denied, is there an appeals process, in which you just discussed a little bit?
Yeah, we definitely always appeal, whether it's to the private insurance company, and sometimes we actually have appealed to the manufacturer directly if the PSP has, say, denied compassionate. Patient just can't afford to pay any cost to the drug. And also to Ontario, Cancer Care Ontario, I guess it would be more Ontario Drug Benefit, because sometimes if patient is in kind of like a life-threatening situation where, palliative care is coming sooner than later, then there is a compassionate care program that the physician can fill out forms to get the drug covered within a few days. I think it's like 1 to 2 days. But you have to be sort of end of life kind of for that program. But we would appeal to private insurers, employers, PSP programs, and to the manufacturer directly.
Great, thanks.
You don't know for an answer.
Yeah, that's good. That's good. I'm sure
you're the right person to have on your side, I would say.
Yeah, pretty clear. Jen, would you like to take some live questions now?
Yes, so we have quite a few coming in. We'll take the first one. So Lori is asking, can you please tell us more about the compassion program for patients with ports or PICC lines? Or is there anything you can speak to around that? So that's less around drugs and more about the lines.
Yeah, because those would be IV medications. So if it's an issue with their port or their PICC, that would go to the nurse. If it was compassionate drug IV wise, we would just be responsible for getting the medication in, storing it correctly, signing it in, signing it out, and that sort of thing. But any questions surrounding the PICC line or the port would go to the nurse or the physician.
Okay. And then I have another question here actually about diagnostic tests. And that's interesting because we often think about like having medication covered. And I don't know, does the diagnostic testing, does that fall within your wheelhouse as well? Like if there are diagnostic tests the patient should be having, and we know that there's broad scale ones now, are you able to help apply for some of the compassionate funding for that or for subsidies for that? Or is that really not currently within sort of the Drug Access Navigator portfolio?
Yeah, we're not at my center in particular, we're not involved hugely in that process. I know there's so many like Foundation One, then you got your oncologists, and the physicians usually just get they fill out whatever they have to fill out, and the secretary would send it off and track, because the compassionate drug is not coming from the testing. We're just waiting for the testing results to see if they meet the requirements for that PSP program or compassionate drug.
So in that case, patients really, if they're looking at diagnostic tests, excuse me, they need to connect with their oncologist or their physician about that, and they do the paperwork.
That's correct. Because some of the physicians have the paperwork in clinic. Some of the testing is covered by the manufacturer. Some the patient has to pay. So those are the ones that we tend to get. If the patient has to pay, because they want us to kind of facilitate that portion, because it's not really under their scope. But once the physician receives the testing results back, then they immediately let us know right away to whether we need to get the paperwork started for the compassionate program.
Okay, thanks for clarifying that. Kathy, back to you.
Sure. So a participant shares, I was just diagnosed with breast cancer, and I'm having surgery, radiation, and hormone therapy. Are there expenses that will not be covered that I should anticipate? I'm trying to plan for any financial impact this will have.
Okay, so there could be or there could not be. So surgery, radiation would all be covered. So there would be no extra costs there. But just when you get into the hormonal therapy, that's where we would enroll the patient in the patient assistance program, because some are covered and some aren't. So it depends on what the physician wants to put them on, whether it's an injection or an oral tablet. And also sometimes with the chemotherapy, the only costs that we see are, like like something to keep your white blood cell count up, those injections. But there's a good PSP program for that. And if there's no funding available to the patient, if the patient can't pay, they do offer compassionate drug. But usually our oncologists in most centers, because the Drug Access Navigator plays such a huge intricate part of the team now, they usually will call you down right away to say, I'm starting this patient in 2 weeks. I'm going to need this and I'm going to need that. So we kind of get a head start on what the patient's going to need so that hopefully the day of chemo, the patient doesn't have to worry, and that takes a lot of stress off of the patient.
So basically, anything that is done within the hospital institution, those would be covered under the healthcare
Any
system.
surgery or radiation, chemo is usually covered. Mm-hmm.
It's usually something that you would have to take orally outside the institution, like you say, hormonal drugs. Neutropenic patients will then face whether or not they have to pay out of pocket. But like you say, from what I understand, most often these patients will get something.
That is correct.
Yes. Okay, that's pretty clear. Thank you.
And just Kathy, while we're on, sorry to interject, just while we're on the financial piece, I just wanted to add, and I will put it in the chat, that CVCN has a financial navigator digital navigation tool. So for that particular patient, and it's less around, there is obviously information about accessing drug coverage and whatnot, which Michelle can speak to, but there's also in terms of other supports. So looking at offsetting some of the daily living costs or transportation costs or whatnot, some of those programs are outlined in there. So I'll put that in the chat as well.
Very good. That's a good idea. So my next question. Any insights on the private insurance navigation versus public? Are there differences in terms of ease of access, or do you see patients with private insurance also faced with difficulties in terms of access?
I actually see a little bit of difficulty with both private insurance and public. With private insurance, usually the delay is because these oncology medications are so expensive. I would say 99% of the time, the private insurer wants prior authorization forms filled. So we tend to fill out everything that we can. We leave the medical part and the signature to the physician, but we have to leave that in their mailbox for them to fill out. We have to wait for it to come back. Then we fax it to the insurer, and it takes anywhere from 5 to 12 business days, depending on the insurer, to fax back a response. Now, luckily, most of the PSP programs that we deal with on a day-to-day basis, as long as they know we've submitted the forms, they will advance or start the patient on drug while we're waiting for the funding response. And the same goes for public. A lot of these drugs are exceptional access drugs, which means the physician has to fill out an EAP, which is an exceptional access program form, basically outlining that the patient meets all the criteria for, via the product monograph. So again, that has to be faxed into Ontario Drug Benefit, and then we have to wait for the response. So it's kind of like a little bit of a wait on both sides. But I would say when a drug access navigator is involved, we would call the insurer on a daily basis. Do you have an answer? Has it been reviewed? Whereabouts in the process is it? So we call every day, and I think they kind of get tired of you calling. So we tend to get the responses back a little bit quicker.
Okay, great. In terms of standardizing these processes, would you know, or do you think that it's the same across the country in each province? Are the processes the same?
I've heard from a lot of provinces that it's kind of the same, except for down east. I think it's Nova Scotia, PEI. A lot of the things are covered where they're not covered here. And the same with BC. A lot of the medications that are not funded here are covered a little bit sooner than Ontario. But no, there's definitely a little bit of a time delay no matter what province you live in, unfortunately. But I will say with the public, Ontario Drug Benefit, they are coming out with a new system which should be up and running to physicians, I believe very shortly, in a month or so, where they can just actually log in online and do the EAP, and then we'll get a response within 1 to 2 business days. So they're streamlining their process, and it's all going to be through the computer, no faxes and all that paperwork back and forth. So that should definitely help.
Okay, that's good to know. I have another question here. She writes, or he writes, could you speak to manufacturer-patient support programs. What are these? And how can I access these?
Okay, so a PSP, or a patient support program, is a program that is run through the drug company, the manufacturer that manufactures the oncology medication that is needed. So they formulate a program to help patients with access to their medications. Now, every PSP is different. Some take verbal consent, some want the written consent of the patient. Some offer 100% compassionate drug, down to cost sharing, which means they'll pay 50%, you pay 50%, or they'll pay 70%, you only pay 30%. And then also they have a copay program as well. So if you have private insurance, they will cover the full copay that your insurer doesn't cover. And the same with Ontario Drug Benefit. If patients are on Trillium and they have a Trillium deductible, which everybody who's on Trillium has a deductible, according to their income, the programs will pick up that Trillium deductible and pay that for the patients.
Well, very good. That's great. Jen, how about a few more live questions?
Definitely. And actually just a follow up to that one. So similar to the question before about self-referring, can patients reach out directly to these drug access programs to self-refer? Can they get in touch with the manufacturer directly, or whoever's supporting those drug access program or patient support programs? Or do they need to go through their oncologist or drug access navigator for those?
Like I said earlier, we have had patients that have self-enrolled. The programs kind of generally see what city the patient's in. So then they'll give us a call to ask us if that's our patient. And if it is, they just ask us to submit the form again, because the physician does need to sign and fill out the prescription portion. But they definitely can call the program, because everybody Googles things these days, right? So if you Google a drug, you scroll down far enough, you're going to find that they have a patient assistance program. So they can call and get their file set up and ready to go for when we fax in the rest of the enrollment form. So yes, they definitely can do that.
Okay. But still it ends up at some point circling back to someone at the cancer center.
It does, unfortunately, because they do need to know what drug am I sending. Sometimes they come in multiple strengths, so the dose would be different for each patient. And the physician, I think every PSP form that we do, the physician needs to sign.
Okay. A question, and Kathy, I know half of this question is covered later on. It was submitted in advance, but a portion of it is not. So I think this is important to cover as well. What if drugs are not approved in one province, but are covered in another province? How can patients access that, or can they? And also, what if there's a drug covered in the US, for example, or in another country? Is there a way for patients to access that if it's not available in Canada?
Okay, so if there is a drug available in another province, but isn't available in Ontario, unless they lived in that province and have been in Ontario less than 3 months, then that province would cover the drug for them. But if they've lived in Ontario longer than 3 months, there wouldn't be access to the medication unless a patient's willing to pay, or there's a PSP that would help them out. Now, for the other part of the question, with drugs that are, approved in other countries and just not available in Canada. So the physician can apply to Health Canada through the SAP process. And provide documentation, research, whichever study shows the drug is valid to use, is just not available in Canada. So we submit those forms to Health Canada, and then we get those back usually within 48 hours. And then Health Canada actually sends the approval to us and the approval to the drug company, and then the drug company ships the drug to the cancer center.
Do you see this often? It's fairly rare.
Special access drugs are fairly common, yes.
In the oncology space.
Mm-hmm.
And so then that saves, what about having to travel? So I guess is this another part to this question, and then Kathy, I promise we're back to you. But the next part of the question is, what about if a patient has to travel outside of Canada? What's the process for that? And is there support like through Health Canada also through that special access program, or is that strictly just for importing drugs?
If the patient well, we wouldn't never send a patient to travel unless there's an approval for them to say, go to Texas for surgery that, again, the physician has applied and got approval for. That's just like not available in Canada. But if it's a medication, the patient wouldn't travel to get it. We would arrange all of this paperwork, get the approval, and then the drug company would ship the drug to our cancer center.
And so then is the similar process. So if there's surgery, let's say in Texas, is the process similar, and it's through their oncologist that they would apply for all of the support to be able to do that?
For anything like that, yeah, I definitely would go through the oncologist. It wouldn't go through us.
Okay.
Yeah.
Good. Thank you.
Yeah.
Kathy.
I'm wondering, would it be from hospital to hospital as well, right? The institution also has to get involved in this, correct? If you're going to have a patient transferred over to Texas at MD Anderson for a specialized intervention, right? I would say.
Yeah, I see. We're not really involved in that, so I don't know too much about that. I know, like years ago, we sent a lot of patients to Roswell Park in Buffalo for a medication that's now funded in Ontario. But at the time, it was approved for use in Canada, Ontario, but it just wasn't available. So we would send them over to Buffalo to Roswell Park. They would get their IV treatment and they would come home. And I know their travel, they would monitor their mileage and everything, and they could use that on their income tax and everything. But when it comes to the medications in other countries, we would arrange for the drug to be shipped here. Sometimes it does come from overseas. So sometimes it can take, once we receive the approval, a week or two to actually get the drug, because it's got to go through customs and that sort of thing first.
How often do you think that happens?
That doesn't happen too often. Usually just when it's a new drug that's just come out to market. But yeah, we don't see that a whole lot. Very rare.
So that means that we have, access to whatever most of the world has. So that's a good thing to know, right?
Yeah. As long as it's approved by Health Canada for use in Canada, then we can fill out the SAP forms, yes.
Right. And can you say what the SAP forms are? We're talking acronyms and sometimes...
Oh, I'm sorry. Yeah. So SAP stands for Special Access Program. And it's a form that the physician fills out with all of his credentials, and then all of the physician's mailing address and the pharmacy's mailing address, phone and fax number, the drug that the physician wants, the dose, how much of the drug the physician wants, 1 month, 2 months, 3 months. And then the physician actually has to supply the research studies. And that has to be attached. And that goes to Health Canada. And Health Canada either approves or denies. And then if it's approved, they send the approval to the drug company as well. And then the drug company will ship the drug to us.
Great. Now you never have to say that again. Just say SAP. All our audience will understand what that is.
Yeah.
Thank you.
Sometimes I forget I'm talking to people that don't know the acronyms. Yes.
We all do. But that's great. Thank you so much. So I'm going to read off another question that was submitted to us. And Limpraza, generic name, olaparib, has Health Canada approval to treat BRCA mutated prostate cancer. However, it seems as though it's being used in other countries for treatment of BRCA mutated breast cancers. Are you able to speak to the status of this in Canada? And I believe, Jen, you also indicate that you can speak to this after Michelle has said something around this.
Yeah, so initially when Lynparza was available to breast cancer patients, it was approved by Health Canada with what's called Notice of Compliance with Conditions, which basically means they have rendered the drug safe enough for patients to take, but the drug company manufacturer has to continually supply updated information to Health Canada. I believe that's kind of the gist of it, I think.
Yeah, and it's something that I just wanted to speak to the CBCN piece on this. So CBCN has also written letters to Health Canada in terms of trying to gain access for patients as well. So something that you can continue to reach back to CBCN about as well.
And Lynparza actually for, I believe, metastatic, I believe it has to be adjuvant or neoadjuvant in the metastatic setting, is covered by Ontario Drug Benefit. So if you have Ontario Drug Benefit, like I said, if you're under 25, over 65, or you're on Trillium or disability or ODSP, it is covered under an EAP, which is exceptional access. The physician would just fill out a form and send in to Ontario Drug Benefit to have that approved.
Okay.
Great. So Jen, you'll pick up a few more live ones because I know there are a lot of live questions that are coming in.
There are. So there's actually a couple that are really tied into whether any natural treatments or supplements, or specific question here about medical cannabis oil, or any of those treatments covered through any of the programs you're able to access, or as a Drug Access Navigator able to help find coverage for those various treatments for patients.
Usually those go through the physician. We don't deal with any of, especially natural questions or cannabis. It goes through the physician. They don't refer those patients to us.
Okay, so there's no funding support or navigation for any of those therapies.
I see. I'm not sure because we don't deal with it. I don't know what type of funding is available. I know there was a company that provided medical cannabis before it was approved, like legalized, I should say, in Ontario. Mm-hmm. So I would think maybe that program is still not available, and we only used it once. I've only ever used it once in 16 years. So
okay,
not a good one to answer that particular question on.
I have a quick question, if you don't mind, Jen. Is cannabis used in the hospital without someone bringing it from the outside if somebody's having treatment, or is there because they've had a neutropenic episode, etc.?
Do you mean if the patient brings it in themselves?
Or is it available through the hospital? Is there, like, how does that work for patients?
No, from what I gather, the physicians give the patients a prescription, and then they have to go to an Ontario legalized dispensary to have it filled. Whether they bring it in themselves to take while they're going, maybe for their chemo treatment, is totally their choice. But usually it goes through the physician.
Thank you. Go ahead, Jen.
So back to provincial coverage, there is a question around, are all drugs available in all provinces? And you spoke a little bit about this, but I think you sort of touched on it before. Are patients across the country having access to all the same drugs?
I'm not 100% sure on because I only deal with Ontario, so I'm not 100% sure, but I would think if it's drugs are going through Health Canada, that they should be available in any province.
So they may be available, but not necessarily publicly funded.
The funding might be different province to province, but the drug should be available, yes.
Right, so it's legally allowed to be sold in Canada and approved for that indication. So technically you should be able to have access to it. You just may have trouble finding the funding depending on the province.
Depending on the province, yes. Yeah.
And then one more question, and then maybe Kathy, I'll send it back to you. But so the question is, are the oncologists actively aware of the drugs that are available that are not funded by the provincial healthcare programs?
Yes, they are, because all the manufacturers have their drug reps that go around in their territory to all the cancer centers and try to speak with the oncologist directly. And most of the oncologists have connections, to the manufacturers. I would say in my center particularly, most of the physicians have come to us to say, hey, by the way, this drug is going to be coming down the pipeline. But our drug reps in Ontario are fabulous. They come around to the center and they know right where the navigators sit and will provide us with all the updated information, the product monograph, the indication, what PSP is going to look like, what they're going to cover, if it's compassionate or not compassionate. They give us the enrollment forms. They give us online enrollment forms. So we're always pretty much up to date on what's new and upcoming, or prior drugs that have been out for a while. Yeah, I just have something to add with the natural drugs as well. Physicians should always consult their oncologist before they start anything like that, because it could have an impact if they're on chemotherapy. So I would advise patients, if they're going to go down that road, to always kind of run it by their oncologist first.
Well, we had a great session. Our last Q&A session actually was with a naturopathic doctor who works who works in an integrative care setting. And so we sort of dove into that a little bit more in terms of ensuring that your oncologist is aware of what you're taking, or having those discussions to make sure that they are not going to impede the efficacy of whatever cancer drug you're on. So definitely something that comes up quite often.
Great.
Kathy, back to you.
Sure. Okay. I just wanted to make one more comment, is that it's nice to hear that the medical community touches base with each other within, each provinces, and at least we know that everybody is aware of what's going on. That feels, comforting.
Exactly. And, like I said, patients can go on to the Ontario Drug Access Navigator website. If they have any questions, they can, and we actually disperse the questions depending on where the patient's calling from. So if they're calling or leaving a message from on Toronto, we'll pass them off to a drug navigator at the closest cancer center to where the patient lives to answer the question for them, because 9 times out of 10, the patient will be a patient of that particular hospital. So we don't just randomly answer questions. And another good thing about Odano for patients to know is that we all communicate together all across Ontario. And if I had a patient come in and say, I heard about this drug, how do I get it? If I haven't heard of it, all I have to do is email my Odano members. Somebody always has the answer. Then we can get back to the patient.
That's great. That's good lines of communication. That's fantastic. That's what we need for the patients, to ensure that everybody gets proper care and access.
Yeah.
So I'm going to go to the next question that was submitted. And it reads, are there any types of drugs in particular that you have noticed patients having difficulties accessing? For example, metastatic drugs or supportive medications or adjuvant therapies. In other words, which drugs seem to be posing the biggest access challenges for patients?
I would say the biggest issue these days is more along the lines of the new immunotherapies and biosimilars. Not as much as the immunotherapy, but we're having the most difficulty getting the immunotherapies. And I'm not sure, like, the private payers are not gung-ho on just paying for this medication that's going to cost them $100,000 a year or whatnot. But the other drugs, kind of just the metastatic drugs or the oral chemotherapies or the hormonal injections, we don't really have a lot of issues accessing those medications. It's more the more complex IV medications that pose the biggest challenge for us right now.
And would you say that's across the country as well, I guess?
I believe throughout Canada for sure. It is getting better, but the problem is you're always getting new drugs coming down the pipeline, which are both oral and IV. So the more drugs that are coming, it's great that we're getting these new medications for breast cancer patients. Myself, I've been on this chemo that I'm on now since a year, November, and I'm lucky that my insurance just covers it and my copay is very small. But a lot of the newer medications, like I have 4 new medications in front of me that I just found out about today. So 2 are IV and 2 are oral. So getting coverage for these is going to be a little bit more challenging than, say, the older medications or the ones that have been on the market for a few years plus.
Do you think that's directly associated with cost? Like you mentioned, like there's less inclination to pay for something that's $100,000. Is there, maybe there's a way to sort of piece some of that together, because at the end of the day, to the patient, if that's the therapy that's going to work for them, then
and definitely there are patient assistance programs for those immunotherapy drugs as well. And when the programs first come out, they usually only come out for a certain period of time. So it has to have an end date at some point, and they're hoping the provincial government will pick up funding, so forth. But in the meantime, they usually offer compassionate drug when the programs are first starting. And once you've been started on drug, when the program closes, that program will continue, manufacturer will continue to provide you drug as long as you still need the drug, even though the program is closed.
But not to anybody coming on new.
No. So when the program for the compassionate portion closes, then they move to more kind of like cost sharing or copay. So if you have private insurance, they'll cover the copay. If you're on Trillium, they'll cover your Trillium deductible. And that's kind of the route that they usually go. Not for every manufacturer, but for most.
Yeah. And what's the extent of time that usually these drugs are on compassionate care, and then they move on to the next system? How long do these drugs stay on?
For the patient, like how long the patient?
Yeah.
You never know. Some patients respond well and some patients don't respond. Some patients can be on drug for 3 months, 6 months, 12 months. It just depends if it's working for the patient. So the chemotherapy I was on before this one, I was on it for 3 months. And then when I had my scan, then things had progressed quite a bit because that particular drug just wasn't working for me at all. So, but yeah, I'm on this new chemotherapy that's been over a year and it's working wonderful. So every patient's different and every patient's going to respond to a different timeline.
Right. Okay. Jen, I think we might be getting questions, right, around this topic.
We have some, actually. We always end up going back a couple of questions because they generate additional discussions. So one sort of just asking for clarification around the out of province access. So this person's clarifying, if I live in Quebec and need a drug in Ontario, I would have to live in Ontario for 3 months before I'm covered under the Ontario program.
Yes, you have to be in Ontario for 3 months before you'll get issued a valid OHIP card. Okay,
so hopefully that was a quick, easy clarification. Thanks, Michelle, for that one. And then this one, if someone has been diagnosed with metastatic breast cancer and they've been on Ibrance, would they qualify for boost drug to help bring their white blood cells up? So similar, Joanne says, similar to Neulast when she had chemotherapy. So are those supportive types of medications covered? And is that something you help patients navigate?
Yes, we do navigate. It is covered by Ontario Drug Benefit. So if you're covered under drug benefit, whether you're over 65, under 25, on Trillium, ODSP, or disability, then it would be covered. But there are PSP programs for all of those injections. So anyone with private insurance, we would enroll to get the copay covered.
Okay.
They are pretty much funded. And most private insurers pay for them as well.
So there should be a way then to somehow piece together the funding for that.
Yes, that's typically a drug that we don't have any problem accessing.
Great. Good to hear. Okay, Kathy, back to you.
Okay. As this question, as someone who navigates patients through this incredibly complex system, what would you like to see implemented to make things easier for patients to access treatments?
Well, I know we have a lot of good ideas on how that could work or how that scenario would look. And at one time at my center, we thought about having a form that the patient would fill out on their first visit with, if they're on Trillium, they would put their their Trillium file number, or if they have private insurance, they would fill out all that and it would be placed in the patient's chart. But then our manager thought, well, that's going to end up being a lot of work if you have to give these forms. But we thought, well, we could have that in the new patient package. And then you get questions, well, the patient's going to take the form home to fill out and they're not going to bring it back. So we're going to have, some patients will have the form and some patients won't have the form in their chart. So I'm not sure what could be different other than, maybe the drug navigators at each of the centers, make the oncologists aware that they would prefer to see the patients on the first visit, just so that you know what the kind of treatment plan is going to look like, what the patient might need and what they might not need, and kind of like a timeline on when they're going to need treatment to start. I think that's the only way we can do it. We can't possibly see every single patient that walks through the cancer center doors because they don't all need your help. We do work very closely with our pharmacists who will let us know immediately if a patient's having any issue with drug. And I'm very lucky to work at a center that the oncologists all support us 100%. And they call us immediately when I don't need the drug for 2 weeks. So they kind of give us that headway. So, I mean, I don't know how we could streamline it any different than what we're doing, because each cancer center is different and how they do things is different. So it's not something that could be implemented, I guess, so to speak, throughout Canada or throughout Ontario.
How much does the patient's voice weigh into this? Like when they need something, what would you say around that? Like how important is it for a patient to also be part of this navigation?
Well, I think it's very important because they're the patient. They're the ones that need the chemotherapy. And we don't like to see patients wait, to start their treatment. And they're already under so much stress dealing with their diagnosis or, going through radiation, chemotherapy, recovering from surgery. So all of that just elevates your stress level. So we try to take all of that stress off of the drug navigation part. But we also keep them in the loop. So if I've called a patient program to follow up on a certain patient because I haven't heard for 2 days, I'll call the patient to let them know. I called the program today. They tried to call you 3 times. They left messages. You haven't called back, or it's in the works. We'll know by tomorrow. So we always keep the patients up to date on where they're at or kind of where they are in the process. So that way they're not at home wondering what's going on. I haven't heard anything. So then they don't have that stress of knowing what's not going on. So they're always up to date on where their application is.
I would imagine that you see a lot of patients that are scared, and it plays on their psychological, feeling about, oh my God, am I going to get this or am I not going to get this? So even if it's something that you reassure them and say, don't worry, we've done this, you'll get it. How much of a burden is it in a patient's psychological,
well, it definitely is a something that I can relate to because I've been a patient since 2013. So, before I was diagnosed with breast cancer, I thought I knew what the patients were going through. I really did. But when you're on the other side, you really do have a whole new perspective on the stress. And it's not just worrying about, oh, I have to go for chemo tomorrow. Am I going to be sick this day? Can I go to work? Am I going to lose my job? Am I going to get approved for disability? They have all of these other kind of branches that they're worrying about, not just their drug therapy. So, it's going through it myself. I try to reassure them. And sometimes patients will call you every day and you'll say, I'll call you as soon as it's approved, but they're going to call you later that day. And you know what? We don't mind that because we know how stressed out they are. So, you know, we do the best to try to get the chemotherapy as quickly as possible for patients. And we also, if we see that a patient is struggling, ask them. You know, we have a wonderful social work department. We have a lot of we have psychologists now on site. You know, would you like us to put in a referral so you have somebody to talk to? And most times the ones that you ask say, yes, please. So we'll put in referrals to social work for a lot of patients that we see are really struggling.
And I guess if there's a peer mentor, that somebody who has gone through the process, that's also something that could be used in order to help them wait this out. Because not only is this a problem about being fearful of accessing drugs, but it's also fearful of everything else and waiting for test results and waiting for reports. That's just layers and layers.
Very stressful.
of anticipated anxiety. So it's just compounding all the time. Thank you. Thank you. So Jen, do you have any live questions?
Yes. So one about actually electronic medical records. So in order to have patients involved in their care, is there an avenue, and this may be a little bit out of your scope of work, but maybe you can speak to what's available at Juravinski, and this may be applicable to some other cancers as well, but is there an avenue where patients can add information into their electronic medical record, or where you can have payer information added into there? So like my chart or anything like that. Is there a way to also navigate some of the financial pieces within those electronic medical records?
Yeah, so we can add, say, a patient's insurance into their into Mosaic, which is one of the systems we use. The patient's not able to access that part.
Okay, but the healthcare professionals can. You can add all the private payer information.
But if they wanted to view any of their lab work or their MRI reports, they can log into my chart. But I believe it doesn't go into my chart until the physicians read the reports. And then it gets, so sometimes it can take up to 20 days, I believe, for it to show up in my chart.
And that, I think, differs from, well, province to province. Some provinces have these lovely province-wide electronic medical records, and some provinces do not, unfortunately. So some of us are left with like institution to institution, whichever platform happens to be used.
Yes, and I know at the Juravinski there's a new system in the works, but I don't think it's just for Juravinski. I think you're going to be able to access anybody's records, no matter where they are, but it's not going to be in effect, I believe, until next year. But I don't know what it's going to entail, like what kind of information you can store in there, because I'm not involved in the process.
So we'll have to wait and see. For anyone in Juravinski, you'll have to wait and see what that is. Another question around the Compassionate Access Program. So you're enrolled in the Compassionate Access Program, patient support program through manufacturer. That's great for the patients that get in. But to Kathy's point, that what happens, like what do you do to the patients then that haven't met that cutoff? So that compassionate support program ends, the PSP closes, and another patient needs it, but it's no longer funded. It's not funded publicly yet. There's this gap, which we see for some therapy. How do you patch together the funding for that? Or can you, or does the patient go without?
No, well, the PSP doesn't usually close. They just close the compassionate. They have a date for compassionate ending, but they usually have some type of support program after that. So they might ask you for your last year's income tax to see what the yearly household income is. And then the drug company would decide how much they'll fund and what you would pay. You could have private insurance that approves it, and the program would cover the copay. So we do still get patients getting access to the medication. It's just a little bit more difficult than straight compassionate.
Yeah, it's a little more piecemeal. Do you have patients, do you see like how, I don't know how often, might be asking you to put a number that isn't there, but do you see a lot of patients who forego the drug completely because they cannot afford even the smaller amount of cost that would be on those drugs if it's not available compassionately? Or are you usually able to sort of piecemeal it together?
Yeah, I would say a good majority of the patient programs do pay those copays. And if it's a small copay, they would just waive it. And sometimes I shouldn't say this, but I've sometimes paid copays for patients. My coworkers have done the same. A lot of times it's not an issue. We usually have some way of getting the copay covered. And we can also go through our social work department, and they have kind of like a checklist, and they'll come over to see the patient and they'll go over the checklist. And sometimes our social work department, I'm not sure where they get the funding for that. They don't tell us and they won't tell us. But if the prescription's under a certain amount, then they will cover it. So
that's a great resource to know about as well. If it's not something that's able to necessarily be covered with the Drug Access Navigator, there's still outstanding amounts that a social worker might be knowledgeable about, programs that are sort of outside of the drug space that may still help bridge some of those gaps.
And we got to remember too, some of the programs that are doing that copay support, where the patient has provided their, notice of assessment from the previous year. So, I mean, if they've made a huge amount of money, and, paying a small copay is usually not a problem. It's more kind of like the patients that are on ODB, like Ontario Drug Benefit, that have the hardest time, but usually those copays do get covered.
Yeah,
it's very rare a patient goes without drug.
But it's still not the answer, right? Yes, there's something outside the box, but that's
and sometimes if we absolutely cannot get the drug that the physician asks us to get, like if we just absolutely can't get that drug, then the physician will go to his plan B. Okay, well, can you try to get this drug for me? So by the time the patient sees us, usually they've kind of gone through the typical lines of therapy that are covered by Cancer Care Ontario. So their stress level's high. If the physician wants a drug like ASAP, then stress on us to get it done within a day or two. But if we absolutely can't do it, the physician usually always has a plan B, I guess, so to speak, like a backup plan. And okay, well, then let's try getting this drug. And like I said, it's extremely rare that we are not able to get the drug covered for the patient.
I would hope that not too many people are left behind.
No, and I think that's another reason why having a drug access navigator in every cancer center is so vital. I think it's so important, and we have gradually over the years become not just a luxury. We're actually a need, like we're actually needed there.
I think all the patients would attest to that who've had access to a drug access navigator, in terms of even just filling out and navigating the paperwork that's involved. Sorry, Kathy, I cut you off.
Yeah, it's very stressful for patients. So we try to fill out all the forms as much as we can. Even Trillium applications, I'll just say to the patient, you just sign it and I'll fill out everything else. Just it takes the stress off of them.
Yes, that alone is such a big help. It's a lot of work. I mean, I know colleagues and patients in the United States, their paperwork is endless. So can you imagine?
A lot of paperwork. And of course we have to store it for so long too. So our filing is crazy, but
I would hope that, and again, hope, I'm always using the hope that our healthcare system would one day understand the frightful feeling that individuals have, knowing that there's something and they have to go through all this to maybe not get it. So is there a way that they could understand this better?
Well, I think the biggest issue surrounding that is a patient just hears, I need to get this drug. But when you go back to the start of when the manufacturer applies, I think they submit it to the new drug funding to Health Canada. There's like 8 or 9 steps, different pieces of the government that this drug company has to go through in order to get the drug to market. So I think it's such a complex issue, that patients don't really think about how the drug got from point A to point Z. And it does take time, unfortunately.
Yeah. And unfortunately, it shouldn't be the patient who needs the drug's problem
to
worry about how it gets through that to your point, 8 or 9 step regulatory process. What really matters
I just think I need this drug and it should be here today. And I really do think sometimes the process of getting the market or the drug to market is a little bit slower than it could be.
We would agree.
That's my personal opinion. Because sometimes you get people's applications denied for like the silliest little reason. And we're just like, oh my gosh, like that's insane, you know, and you appeal it and provide more. I overload them sometimes with like 90 pages of research. It's like, there you go. Now then it comes back.
Yeah. Overload that they'll get to the point where, okay, this is a go. I'll just, here you go.
So then we have another question from Carrie, actually, who said, I was recently treated for early stage breast cancer and worked through a drug access navigator. I didn't know, however, that there was a list of patient support programs and Odano on the CBCN. So how do we make sure that patients can access, I guess this is more for CBCN, access the CBCN info? And I think that's a great point and a great question. It's something that we're working at, and we're committed to trying to ensure that our information is in cancer centers across the country so that patients and healthcare professionals, so oncologists, drug access navigators, nurse navigators, pharmacists are aware that CBCN has these resources. And so I'm glad, Carrie, that you're able to connect with us now, but that's something that is still a work in progress, and we're really trying to ensure that information is out there. And then, sorry, Michelle, you look like you were gonna.
On the drug access, if you go to Odano, we are also trying to add links to different associations and, you know, different places where patients can go for help or, you know, support. But I mean, it's so hard to get everybody to know that you're here and you're there to help them, you know, so we just try to keep spreading the word.
Well, and a lot of that comes down to, and I think it's been demonstrated that even within your own cancer center, there's a great working relationship with all of the multidisciplinary team, and how critical that is, really, even in terms of sharing information.
Yeah, absolutely. Yeah, they're wonderful.
This question's a little bit out of the scope specifically around your role as a drug access navigator, but more to, we've been having lots of discussions around national pharmacare. And Nancy's wondering, like, what's your take on that? Do you think that national pharmacare will make this better and less time consuming for the oncologist, but also maybe, I wonder, for the drug access navigator in terms of trying to access drugs for patients?
I'm not 100% sure. I haven't really followed all this national healthcare stuff, but I know there's so many complex issues, whether it's in Ontario, whether it's in Canada, or whether it's, you know, nationally. I don't know. I don't know how to answer that question.
I guess we'll see if it's been talked about for quite a while, but understanding what that actually looks like and the impact. But yeah, just more so wondering, I guess, if those conversations were taking place or it's a wait and see as it rolls out, since we're not quite there.
I haven't heard much. So I really am not 100% sure on what would be better or maybe worse.
I guess we'll have to see if it's implemented in the next 4 years then, with the government. So another question coming in through the chat. Sorry, Kathy, we have quite a few coming in through here. So I'm going to read it. Go ahead. That's okay. Does drug eligibility include undergoing treatments that are approved and funded before being able to access drugs that may be more applicable but not funded? So sometimes, do you as the patient have to go through X, you know, if you're supposed to have this drug first, then this drug, but this one might actually be better? Do you sort of have to jump through the hoops of having had the other two first before you can get funding for the third one or the second one? Or do you see that often?
Yes, we do see it often, only because some of the drugs, well, actually, I would say a lot of the drugs kind of follow a chain reaction. So you could have full access to this drug, but you had to have failed on this drug and this drug. Or you could get access to this drug just right off the bat. Sometimes there's a couple different drugs manufactured by two different drug companies that you could do either or. So we would do paperwork for both drugs, and whichever one gets the funding first, we would start the patient on that because they're typically the same drug, just made by different manufacturers. But yeah, I would say most times it does kind of follow a chain reaction that you had to have failed, or you had to have not necessarily failed, but you had to have, say, had docetaxel, or you had to have had cisplatin, or you had to have tried fulvestrant before you can have this drug. So we do see that a lot, yes.
So I guess they have to do first line, second line, and then go on.
Exactly, yes.
There. But is it possible that I'm understanding a lot of the drugs now, a lot of the drugs that people need access to don't have to follow that path anymore? Like, there are more drugs that are coming out. Yeah. They're personalized drugs that you don't need to do the first line, second line before you can get that, right? That's happening more.
It is, yes.
Okay, that's good.
And now that we're speaking about lines, so we have a question from Cheryl. As a metastatic HER2 positive patient of almost 3 years, she's still on her first line of Herceptin and Perjeta. She's never spoken to a drug access navigator, and this line has treated her well. So it sounds like it's going well, which is great to hear, Cheryl. But if and when I need my second line, how do I know the one they offer is the best one to do? So this is more of a question for an oncologist, but do you have any thoughts around that?
Yeah, definitely a question for their oncologist, but I would think most oncologists typically will give the patient or start the patient on whatever he thinks is the best option for the patient, or what's going to work the best.
Well, and it's interesting too, because fortunately we've seen a lot of advanced therapies in metastatic breast cancer over the past 10 years. And so while we know it's helpful to know, like, okay, what's available second line and what's out there, right? And what might be suitable, depending on, and it sounds like Cheryl's had a lot of success with Herceptin and Perjeta. So depending on how long Cheryl's on that, if it's another year, if it's years more, what might actually be the standard of care in second line right now might be different in a few years, depending on how long that this treatment successfully works well, and hopefully it continues to do so.
And, a patient always has the right to ask their oncologist any question. So in Cheryl's case, Cheryl, you could say to your oncologist, when and if I fail Herceptin and Perjeta, what would you think would be the next line of therapy? And a lot of times the physicians will ask us to look into that, so it's in place when we need it. So
that's done preemptively sometimes with the Drug Access Navigator.
Yes, absolutely. You can ask your physician anytime, like, when I'm done this drug, what is available next? And then we could look into that and have it set or not set, kind of when that patient's ready to start. We have one physician that does that all the time. So he doesn't need the drug right now, and we let the patient program know the patient's not going to start now. We just want to know, are they going to have funding? Can we do the insurance forms or whatnot, and make sure that we have approval for when the patient needs to start?
And that is really interesting.
Yeah, proactive. Be your own advocate. Stand up for yourself. Ask questions. No question is stupid. Ask questions. It's your health. It's your body. You have a right to know.
That's right. And that's accepted. That's perfectly accepted. They can apply and just wait till the time it comes.
Yeah, do that quite often now. But we have to watch the timelines too for when, say, the patient programs are going to close. So we might say get approval for a drug for a patient, but they're not ready to start. So we'll put a note in our calendar to notify us, okay, we need to now ask the physician at 6 months forward. The program's going to close next week. Is this patient going to start? Because if they don't, then they're going to lose the funding.
Yeah. Yeah. Is there ever a situation where programs close just abruptly without any notice, or do they actually stick to their timeline?
Actually, most times they get seem to get extended a little bit, which is lovely for the patients. I think that's only ever happened to us once, that a program closed and we were not notified, and the physician wasn't notified either. Yeah, I think, our drug reps are fabulous at keeping us up to date on what's going on with their patient programs.
That's good to know, because for the sake of a patient that's on something, and then all of a sudden to, be notified that, whoops, that's good to know. That's good to know.
Yeah.
We have one comment and one question. So the comment from Nancy says, we seem to be spending a lot of time and money fighting to get drugs, and it'd be so much better to use the money on the drugs themselves or on research for new drugs, which I think we're all in agreement with you, Nancy, on that comment.
It is. Yeah, I know. It just goes back to, it's really hard to know the whole drug process, and the timeline is actually much longer than patients realize. And, research does have to be done on these medications before they're approved. And I don't think anybody would want to start on drug if it's not safe for them to take. So I know patience is a virtue, but when you're in our situation, today is today, and you have to make the most of today. So
absolutely.
Yeah. Do you have advanced notice of what's coming down the pipeline on some drugs?
Usually the drug reps always let us know. I would say it's very rare that we don't know when a new drug is coming out, because they always, I would say 99% of the time, they'll have a program of some sort. So they definitely want us to know that it's there and the start date, so that we can get as many patients enrolled that we possibly can. It's for the patients. So yeah, they definitely let us know.
And do they also give you a heads up on what's in the early stages of clinical trials, or even at bench research? Do they give you a complete overall on what's going on?
Not always. If for some reason we absolutely are having a lot of trouble trying to get a drug approved for a patient, we will email the oncologist just to let them know. And sometimes the drug company, the medical affairs department, will let us know if there's trials going at a certain cancer center. And then we would email the oncologist to, are there any trials that the patient might be eligible for, because we just can't get the drug funded. So we definitely, we try every avenue possible to try to get the drug funded.
Okay, well, that's good to know. Jen, do you have more questions? Or
I have one last one here for the time being, and it is, and I don't know if, we don't expect you to know this one specifically, Michele, but maybe through your network, which province has the most drugs publicly funded? So if you want the greatest drug access,
I think it's BC.
I think you're right as well. I think that generally seems to be what we hear as well. So BC is the place where you'll have the greatest access.
Yes.
And nicer weather.
And the mountains.
And the mountains.
And beauty.
Yeah.
It's our beauty province anyway.
Yeah.
So Kathy, back to you.
Yeah, so I'm going to close off this question unless there's something after this, but it's a good way to give you an opportunity. And the question is, given that you're both a healthcare professional and a patient, what is something that we haven't addressed in this session that you think is important for patients to know?
As a navigator and a patient, the biggest thing I can say is just be your own advocate. Fight for yourself. I did research when I found out I had metastatic breast cancer to my liver and to my spine. And both times I knew something was wrong and had scans, I was right. So do what's right for you, fight for yourself, ask questions. No oncologist is going to get mad at you for asking questions. Ask, what's next for me? What drugs may I need next? Does this center have a drug access navigator? Ask the oncologist, do you have anybody available that does this? That's the biggest challenge, I would say, as a patient and a navigator, is just, you have to sometimes be on top of your own treatment plan. know what's next. Like I know what drug I'm going to be going on next when this one fails, when and if it, because we know cancer's smart, right? And it figures out a way to grow on your treatment eventually. So I know what drug I'm going on next. I already know if it's covered. So you have every right to ask those questions. So, you know, take it full advantage of that.
And what about those patients? Because all of us are not the same, right?
No,
and some of us could do this exactly what you're saying, the advocacy for ourselves. We have support that will do it for us if we're weakened or if we're not feeling well. Yeah. What about those that are very, you know, uneasy to do this sort of, you know, advocacy for themselves? The energy level isn't there. And patients come with comorbidities as well. Their mental state may be compromised as well. So who looks after those patients that don't have that big voice?
Sometimes the oncologist, sometimes the nurse, sometimes we'll recognize it. And like I said, we refer a lot of our referrals to social work. I myself see a psychologist at the Juravinski, and she's really helped me come to terms and I didn't even know she was there and I worked there. So, and talking to her has made a huge difference. But yeah, I guess when we notice people that are more shy, and we do have patients, their power of attorney, like whether it be their daughter, their son, you know, their mother, their father, sister, brother will call in and say, hey, you know, like I was at the house yesterday, they don't look so good, or, you know, I think she forgot to take her medication. Should she skip a dose or just take the missed dose and then take the next dose? So we do get a lot of family members or POAs calling in on behalf of the patients as well.
Yeah. And I guess it would be good if a patient knows themselves to be that way and say, look, I'm not one to be able to be that forceful, or that energy is not within me. Please help me out. At least the doctor and the healthcare team is aware that this patient is a little more vulnerable than somebody else. And maybe the support system isn't there. I guess what I'm trying to say is that I don't want anybody to be missed.
No, I know. And I mean, there's always probably one or two people that slip through the cracks, but I know at my center, we are so hugely involved in the whole patient navigation system with medication. There's 5 of us that do it full time. So that kind of gives you an indication on the referral amount we get on a monthly basis. It's like hundreds. So, I mean, we're definitely a needed role in all cancer centers for sure.
Thank you.
And I love all our drug reps. They're just fantastic.
Good. That's good to hear.
Yes, I made many good friends.
I'm sure they would like to hear that too.
They're wonderful. Yeah, we couldn't do our job without them. We really couldn't.
Good. I'd like to hear that. Well, Jen, I think we're almost coming to our closing time. If you have any last questions, please go ahead.
So we don't, and actually that's perfect. It's right on time. I think if there's one thing we've learned today, it's that we all need a Michele. So find your Drug Access Navigator. Find your Michele who will help advocate for you and help get you the treatments that you need. I mean, Michele, this was incredibly informative.
Yes. Thank you, Kathy and Jen, for inviting me. I mean, I try to help as much as I possibly can. And yeah, thank you for the opportunity to speak for you today.
Thank you so much for being with us.
Thank you.
Over to you,
Kathy. Thank you. Yes, Kathy, thank you for hosting this one as well. Another Q&A session. Michele, for joining us. And then also, I just wanted to thank all of our sponsors for today. Again, our gold sponsor, Viatris, our silver sponsor, Novartis Oncology and Roche, and our bronze sponsors, AstraZeneca, Knight Therapeutics, the Ontario Trillium Foundation, and Pfizer Oncology. We will be sharing a short survey back with participants, so watch for that in your inbox in the coming days. We'd really appreciate your feedback. And thank you everyone for joining us. We look forward to connecting on the next Q&A session. Have a wonderful day.
Thank you, Jen.
Thank you, Jen.
Thank you.